two main types of cancer that arise in the kidney. One is renal cell carcinoma and the other is transitional cell carcinoma. Transitional cell carcinomas arise from the renal pelvis and calyces, from the transitional epithelium that lines these structures, but renal cell carcinoma arises from the renal tubular epithelium. This mini tutorial will cover the incidence, risk factors, presentation, types, and prognostic factors including grading of renal cell carcinomas. In the UK, approximately 3% of all cancers are renal cell carcinomas. The peak age at which they occur is between the ages of 65 and 80. They are rare under the age of 40. Renal cell carcinomas are more frequent in men, with the ratio of 3 men to 2 women. The majority of renal cell carcinomas are sporadic. This yellowish focally hemorrhagic tumour arising in the renal parenchyma is a typical example of a renal cell carcinoma. There are a number of risk factors for renal cell carcinoma. The two main risk factors are smoking and obesity. With smoking, there is an approximately 50% increased risk of developing renal cell carcinoma, and with obesity, the higher the body mass index or BMI, the higher the risk of developing renal cell carcinoma. Other risk factors include hypertension, renal failure and acquired cystic disease, a family history of renal cell carcinoma in a first-degree relative. Patients with von Hippel-Lindau syndrome are at increased risk of renal cell carcinoma. Finally, patients with sickle cell disease are at risk of developing a particularly aggressive type of renal cell carcinoma called renal medullary carcinoma. Renal cell carcinoma may present in a number of ways, including hematuria in 50% of cases, pain, and a mass. Sometimes there may be confusing paraneoplastic signs and symptoms including fever, weight loss, malaise, high blood pressure, night sweats, etc. These days, renal cell carcinomas may be found incidentally as a result of the increased use of radiological imaging techniques such as CT, ultrasound, and MRI scans. There are several varieties of renal cell carcinoma. The most frequent is the conventional clear cell renal cell carcinoma, accounting for approximately 70 to 80% of cases. The next most frequent type are the renal papillary carcinomas, and these may be either type 1 or type 2. Approximately 5% of renal cell carcinomas are a variety called Chromophobe renal cell carcinomas. Collecting duct carcinomas account for approximately 1% of renal cell carcinomas, and these are particularly aggressive nasty tumours. And another aggressive nasty tumour is the renal medullary carcinoma that occurs in patients with sickle cell disease. Clinically, it is important to differentiate between the different subtypes because some behave better than others at the same stage. For example, Chromophobe and Papillary RCCs have a better prognosis at the same stage than a conventional clear cell renal cell carcinoma, with type 1 papillary RCCs behaving slightly better than type 2. Here are some examples of the different types of renal cell carcinoma. First off is the conventional clear cell renal cell carcinoma. This has a yellow cut surface, quite well circumscribed, and the dark area is a focus of hemorrhage. This is the corresponding histology showing a carcinoma composed of clear cells. And this resembles adrenal, which is why the old term for clear cell renal cell carcinomas was hypernephroma. This is the gross appearance of a type 1 papillary renal cell carcinoma. This tumour is quite well circumscribed, has a yellowish-brownish cut surface and a rather shaggy appearance. This is the corresponding histology revealing an obviously papillary carcinoma. This is another papillary renal cell carcinoma, and this time it is a type 2 papillary RCC. Histologically, the type 2 papillary RCC has rather larger nuclei and more abundant cytoplasm than the type 1 papillary RCC. This is the gross appearance of a variety of renal cell carcinoma known as chromophobe renal cell carcinoma. As I said before, these account for approximately 5% of RCCs, but they are, for some reason, more common in the Middle East. This is the histological appearance of a chromophobe RCC. The cytoplasm in this case is rather granular. The nuclei are rather irregular, and some cells are binucleated. Most of the nuclei are surrounded by clear halos, and the cells are surrounded by thick cell membranes, giving a rather plant-like appearance because the cell membranes look like cell walls. This is a good example of a collecting duct renal cell carcinoma. It has a pale whitish cut surface and a very infiltrative margin. This is in contrast to other types of renal cell carcinoma that tend to have fairly well circumscribed margins. Histologically, the tumour cells have a tubulopapillary growth pattern, and the stroma is rather fibrous. The prognosis of renal cell carcinoma is influenced by many factors. Poor prognostic features include a high stage such as invasion into the renal vein, a large tumour, the presence of necrosis in the tumour, high nuclear grade, older age at presentation, and also some tumours are particularly aggressive with a poor prognosis, including collecting duct and renal medullary carcinomas. Renal cell carcinomas have a tendency to invade the renal vein, and some extend further into the vena cava. In this case, a piece of tumour that had extended out of the renal vein into the vena cava broke off, producing a pulmonary embolus. This is tumour in the pulmonary artery. Treatment for renal cell carcinoma includes surgical removal such as partial nephrectomy, nephrectomy or radical nephrectomy. The tumour may be embolized. Smaller tumours may be ablated by techniques such as cryotherapy, and sometimes circumstances may dictate that watchful waiting is appropriate. Clear cell and papillary renal cell carcinomas are graded 1 to 4. There are two main systems. The first is Fuhrman, and this is the most well-known grading system, but it has been superseded by the WHO ISUP system that is very similar. In both systems, the grade depends on the lowest magnification at which nucleoli can be identified. For example, if nucleoli cannot be seen at a magnification less than times 400, then that is grade 2. In other words, if nucleoli cannot be seen with anything less than a times 40 objective and times 10 eyepiece, then it is grade 2. If nucleoli cannot be seen even at times 400, then the grade is 1, but if the nuclei are pleomorphic and or the cells have a rhabdoid or sarcomatoid appearance, then the grade is 4. In practice, the vast majority of renal cell carcinomas are grade 2 or grade 3. Here is an example of a grade 2 conventional clear cell renal cell carcinoma. This one is a conventional clear cell renal cell carcinoma grade 3. This renal cell carcinoma has large pleomorphic nuclei, and this is an example of a grade 4 RCC. There are a number of risk assessment scores that have been proposed for use in patients with renal cell carcinoma. This table shows the Leibovich score, and this is used to predict metastasis-free survival in patients with conventional clear cell renal cell carcinoma. It takes into account the stage, lymph node status, tumour size, nuclear grade, and presence or absence of tumour necrosis. Each criterion is assigned a numerical value. These are all added up to produce the score. So a patient with a score of 0 will have a very low risk of metastasis. In contrast, a patient with a score of 6 or more will have a high risk of metastasis.